With an ever-growing older population, senior adults make up the majority of people accessing healthcare. However, despite this, there are still many health inequalities that affect this particular group. In this episode, we're going to explore how these health inequalities can be addressed and look at new services that are being introduced to reduce them. Dr. Cassandra Ng is a consultant geriatrician with a specialist interest in oncogeriatrics. I met with her to discuss the difficulties and considerations when managing senior adults in primary care. What are the issues in referring elderly patients into cancer services?
We have to take into account not just their comorbidities or their age, but also their reserves, their fitness for treatment. Older people are a heterogeneous group, and for some older people, cancer may not be the main priority for them.
Within the group, how do we manage the different people and their different needs?
We have to have a personalised approach to all these people. Let's take the extreme ends to begin with, because that's often easier. I think we have the very fit older adults, referring them to tertiary care, the 2-week wait, and getting them through all the investigations as quickly as possible, and also the treatment. Then you've got the severely frail, the patients, for example, who are in a nursing home, who have both physical or cognitive comorbidities. Those patients, the benefit of cancer investigations and treatment may be limited, and actually the focus needs to be on dignity and quality of life.
Of course, yeah.
But of course, the group that poses the greatest challenge really is the group in the middle.
What would you say are the advantages of GPs doing frailty scores on all their elderly patients?
I think often patients get referred for primary care and there's a real rush to get them through investigations and then the MDT and deciding on treatments. And we're relying on as much information as we can get with regards to the patient's performance status, the patient's previous background, and the patient's frailty state. In the early stages of frailty, we believe that there's some potential reversibility. So if a GP gives us the frailty score, it gives us an idea, and in the ideal world, someone who scores, for example, on a clinical frailty scale of 4 and above, may then see both services right from the beginning, and steps can be put in place to try to optimize and reverse the reversible causes early on.
In an ideal world, every frail patient at the point of referral would see someone like yourself, and all relevant investigations would be organised. But unfortunately, there isn't a Cassandra in every clinic. So how can we, in general practice, ensure that when we refer, things are optimised?
I think every little helps, and some of the information, you've got a wealth of information about the patients on your computer screens. And I think simple things, for example, advising on stopping smoking, looking at, exercise levels, activities, social prescribing, even as little as identifying falls and falls prevention, for example.
Okay.
In some practices, I know you have pharmacists and looking at maybe initially the medication review, stopping medications that are no longer necessary, for example, and also perhaps starting oral nutritious supplements for those who are perhaps malnourished or has had rapid weight loss. In those who are iron deficient with anemia, and supplementation of iron supplements will be useful as well, but also other deficiencies of vitamin B12, folate, or vitamin D deficiency, for example, in those who are at high falls risk and risk of fractures.
Right.
To begin to tackle the problem of frailty and other comorbidities, a senior adult service has launched in Greater Manchester. I spoke to Dr. Fabio Gomez, a consultant medical oncologist and clinical director of the new Senior Adult Oncology Service, to find out more about its aims.
What is the new Senior Adult Oncology Service?
It's a service that we've opened last year, 2022, and it's a service that is there to support our older patients with cancer that really have complex needs, other health problems, and therefore have frailty. And we have two main aims. One is to aid the whole process of decision making, aiding these complex patients and their parent oncology teams to try to make the best decision possible when it comes to treatment. We often see more and more actually that patients might have multiple options on the table, which is a great thing, but makes it more complicated. And I guess that links me with a second aim for the service, which is supporting the patients throughout that treatment. And this is an outpatient-based service that is multidisciplinary, so the team would come in and support them alongside the parent oncology team whilst they are on treatments.
When the service was being considered, why was it implemented in the first place?
We got involved with NHS England on a project about implementing frailty screening. And basically what we saw, if the patient was older, they were definitely more likely to have some degree of frailty, and we had roughly, the number was 40% of lung cancer patients had some degree of frailty based on that tool. And then we could see that they were less likely to be offered a cancer treatment. But often we could see that there was not only that difference, but also for the ones we had decided to treat. For example, if we thought about some systemic treatment like chemotherapy, if they were frail, they were significantly less likely to go beyond one round of treatment. So this was really an opportunity for us to map out that there is clearly a need for those patients. Their outcomes are different. So everything around this is to how can we best select the patient and best support the patient to get the right treatment through the standard pathways, but also accessing research.
So how do you identify patients for this service? As we know, cancer is seen more in older people, and if all patients were referred in over the age of 65, you wouldn't have the capacity and your service would be swamped. So what is the process of making the identification?
Yeah, no, you're absolutely right. If we were to see everyone over 65, that would be the vast majority of patients coming through the Christie. Our focus at the moment is primarily patients 70 and above. And the focus is not just on the age, but the age with other health problems, with frailty, that really makes those patients more complex. This would be a case where we would have a difficult decision, and we have that conversation with the patient. And it's difficult on the patient and the family to decide as well, but the team would come in and do an assessment that could provide a better understanding if the patient, for example, is overall quite resilient, does have quite a few other health problems, but they have been stable, they're controlled, they're as optimized as they could be.
A lot of the patients that you describe have got frailty and possibly other comorbidities. And primary care are often in the ideal place to manage this and diagnose a lot of these problems. How can they be more involved with referring, making patients aware of this very important service?
We really need to raise that profile amongst GPs that this service is here. It's a new service, obviously it will take a little bit of time. Although the referrals come to us primarily from the parent oncology team, we have our contacts on the main Christie external webpage. So patient GPs could contact us if a patient is under us here at the Christie as well. So a lot of the time from the team is actually spent trying to bridge that and contacting primary and secondary care to make sure that we have a package of care for those patients that is a bit more coordinated. Because we don't want to be a standalone service within a cancer center. We want to be a service that is engaged with what is happening in the community as well. So we want to be as supportive and proactive as we can. So establishing that link for us is quite important.
Looking to get more insight into the senior oncology service, I met with Mandy Stamp. Mandy was diagnosed with lung cancer in 2022. Due to her complex multiple comorbidities, Mandy was referred into the service. I wanted to find out if and how it had improved her overall experience.
I have polyps in my stomach, which the gastroscopy gentleman wanted to do a CT scan to see if they'd got any worse in the last year.
And on the CT scan, there was an incidental finding of a lung primary, and that's when everything else changed.
I was treated very well, firstly at Wythenshawe, until various things, and so then they had a general meeting whether how they would go forward with my cancer treatment. Because I've had 2 heart attacks, diabetic, COPD, and my age presumably as well didn't help. So the option was given to me of having radiotherapy.
Do you know how you got involved with the senior adult service? Were you advised to attend? Were you referred in? How did it work?
I'm not exactly sure, but I think somehow through having the radiotherapy and seeing, was then, I think, automatically referred to this new, which is a startup program of helping cancer patients who are elderly. And so henceforth, I then went to a different department, met Dr. Cassandra and various other, the occupational therapy aider and the dietitian Caroline Wilson, And Emily, who was a physiotherapy, came in occasionally, not as often, but I had spoke to her, and I was referred to have exercises at the gym. Lo and behold, I said, I'm not wearing lycra, that's for certain. So I go to the gym once a week, and I was advised then to go and do some yoga.
So it sounds like the Senior Adult Service had a variety of specialists working in-house. How have they helped you, and are they going to continue to support you moving forward?
And a lot of the help came from Caroline, who was a dietitian, who gave me lots, as I had lost 2 stone in weight at least, and that was apparently muscle loss, lots of protein drinks and food to eat, and try and encourage me to eat. I wasn't feeling hungry, but whether that was due to the radiation, the cancer, or any other factors, the gastroscopy part of it, I've no idea.
From what I understand about the Senior Adult Service, they also support you not only with the cancer diagnosis, but with the other conditions, the COPD, the diabetes, and your previous cardiac history as well. Have the doctors and the team supported you in these as well as the cancer?
It wasn't over-mentioned. It was mentioned, in fact, and Caroline, who's a dietitian, was very keen on that side, obviously. But I think the service itself is excellent. I'm very lucky.
I always have to ask this because I am a GP. How was your experience in general practice? And was there anything that you would have wanted more of, or they could have been more supportive with?
They must have received a letter telling them I was having treatment at Christie's, etc., etc. And I had one phone call very vaguely in the morning saying, oh, I hear we've got your diagnosis. Are you all right? Thank you. And that was it. And there was never any follow-up. The trauma of being told you've got cancer, you take it home and you sit and you brew. You sit there and you think, oh dear. And nobody then came just to talk. I think that just a follow-up call, sort of, say, a month later, how are you doing? But other than that, I don't think, they haven't at the time, I realise that, but that would have reassured me that they still cared, that their patient was still ticking on.
It's clear that we cannot simply make assumptions about elderly patients and their needs. Instead, we must offer personalised care wherever possible to ensure decisions are made together with patients and other clinicians to optimise treatment options. The new service in Greater Manchester could be the future of senior adult care, with collaborative working and communication across specialties and services at its core. As a practicing GP with first-hand experience of diagnosing and managing cancer in the elderly, I feel this service would be of benefit and be welcomed in primary and secondary care.